Hello everyone, welcome to this series of podcasts, I and You, where we discuss everything about ophthalmology and life, and we get to know the person behind the ophthalmologist. As a short recap, last time we had spoken with Dr. Upal Shah, who was the mother of the smile surgery, but today I have the pleasure and honor of introducing Professor Dr. Mahipal Sachdev, who is a very compassionate human being above all, and also I would say, in my opinion, one of the last of the stars of Indian ophthalmology. He is a renowned surgeon, a clinician who is, I would say, the best in India and sought after across the world. He is also the man of firsts, or a pioneer in various aspects in ophthalmology. He has done many uh, inventions, many new surgical techniques. All these have come from him. The chairman and medical director and a senior consultant at Center for Sight Group of Eye Hospitals, which was started in 1996. He was awarded the Padma Shri in 2007 by the President of India for his contribution towards medicine. He has authored multiple journals, multiple articles, multiple books. He actually had the first book on phacoemulsification, that is the stitchless cataract surgery. So when I was taking about pioneers, so Sir has been the first of the pioneers in a number of surgeries, starting from the stitchless cataract surgery, that is the phacoemulsification, then coming on to the LASIK, which was, he was one of the pioneers in India, then the Bladeless LASIK and Zyoptics, coming on to the phakic ICL, that is the phakic IOL, wherein a lens is implanted inside the eye to remove the power. Then also coming on to the smile procedure, which was a flapless procedure. He was one of the pioneers and propagators. Then he was also part of the clinical trials of the Elita silk machine, wherein it was similar to smile, but it was much more advanced. So the first in man, that is the first surgery ever in the world, was done by Dr. Mahipal Sachdev. So he is, of course, the man of firsts and multiple more things. He was, and most importantly, he was the president of the All India Ophthalmic Society. But more importantly, he was in 2020, which was the year of COVID. So Sir spearheaded us into formation of guidelines and also multiple rules that were followed throughout lockdown. How despite the lockdowns, eye care did not suffer all over India, and we were actually, lots of societies all over the world took inspiration from India, how the guidelines were set and how eye care was managed during COVID. Also, he's involved in multiple, he's a key opinion leader for multiple brands or multiple pharmaceutical companies all over the world that want his opinion on newer technologies. So welcome, sir. A very short introduction. So we just want to speak with you and want to know your journey and the person behind ophthalmology and how various milestones came into your life. So just I want just a brief introduction. So how you entered ophthalmology and what was the factor that pushed you towards ophthalmology?
Well, thank you, Raghav, for the generous introduction. Regarding your question about ophthalmology, I would just wish to say that I was born to a mother who was a gynecologist and an obstetrician. I had also the fortune of having my elder brother who is a pediatrician, and he had got admission in the All India Institute of Medical Sciences, which you know even today is a pioneer, the leading organization for medical education. And my father also wanted us to pursue the profession of medicine. So I think these were the influencing factors. I don't think there was anybody else who was into healthcare in our family, but these were the influencing factors which actually made me take up medicine as my first choice. Just to say that engineering would have been my second choice, and I did crack the IIT exam, went up to doing a medical exam, but didn't join IIT because I think medicine was my calling. From there on, yes, I was always interested in a surgical field, and in a surgical field, I was interested in wanting to do something which was complete in itself. So rather than going in for, say, general surgery, I took up the first choice as ophthalmology because as an intern, I think that was the first time I did a cataract surgery in a rural setting. And ophthalmology I gave as my first choice and ENT as my second choice when I gave in the exam for my post-graduation entrance. Uh, Ophthalmology, why I chose ophthalmology, one of the main reasons was that I think that the results were reasonably fast. Ever since I took ophthalmology and as things have transformed there, I would say that cataract and refractive surgery, which I have super specialized further in, have the most instant gratification that you have for a patient. A patient who comes in with a cataract and not seeing well goes back within couple of minutes of surgery, goes back with vision regained. And similarly, somebody who has been wearing glasses throughout his life, when he comes in for refractive surgery, he can get rid of glasses. These are two of the things that have excited me. So coming into ophthalmology and then super specialization, I think these were the important things which actually took me towards taking ophthalmology as a career and a profession.
Okay. So you yourself have been did your MBBS from All India Institute, that is the RP Center. Then again you did your post graduation from RP Center, and then you were faculty in AIIMS, and then you were very well placed. And of course you left AIIMS and you went for a fellowship abroad to Georgetown University in Washington. And then of course was the image at that time anyway of having a setup of 86 eye centers around the world at that time? What was the image then?
So, image then was my hunger for learning more, to do more, and to get on to whatever is the best possible technologies, best possible skill sets that is there. All India Institute of Medical Sciences, doing my MBBS, later on doing my post-graduation, then senior residency and faculty. I spent close to 20 years in All India Institute of Medical Sciences. That again helped us develop ourselves into a complete medical graduate, and then RP Center into a complete postgraduate and a faculty later on. The biggest advantage at that particular time was that as things are today in India, they weren't the same in India earlier. You had a controlled economy, and even getting to import equipments was a big deal. So it was All India Institute of Medical Sciences rather than the private sector, which was not even, I would say, not even in its infancy. It was just about maybe started much later. So all technology would come to All India Institute of Medical Sciences first. So that was a big positive that we could lay our hands on technology. Apart from that, there was only one AIIMS at that particular time, and that was the hub for the greatest of minds and the greatest of surgeons, the greatest of clinicians working there. So there couldn't be anything better. The atmosphere of All India Institute of Medical Sciences was great. And you had only a batch of 50 medical students. So all in all, very focused teaching, very focused academics, as you can say, research, clinical acumen being established, having access to technology, having access to seeing great surgeons operate, etc. I think that is the main thing that has made me, I would say, from the trainings that I got from All India Institute of Medical Sciences. And then from there on, whatever was more that we thought, that's what initiated me into going for a fellowship in Georgetown University. And that is where we worked on several things which have actually come to fruition only very recently. For example, we worked on the meibomian gland dysfunction, which has become very big now over the last maybe 5-7 years, and that was work done in 89-90, confocal microscopy, wound healing for radial keratotomy, etc., endothelial dysfunction. So there were a lot of things that we did, and that is where I actually felt that people in US aspire to do more and to achieve more. And I think that was the turning point where I actually decided that I could possibly get out of All India Institute of Medical Sciences after having honed my skills, acquired certain knowledge base, academics, etc., to step out and start something in the private domain. And well, I think I was fortuitous. God has been kind, and from that perspective, I think it was at the right time, with the right skill set, going into with phacoemulsification and then LASIK, which wasn't which wasn't being done by too many people, and that's how the journey began. And a difficult decision at that particular moment, at the age of 38, leaving a secure job, but no regrets. And I think we have been able to create really world-class, super specialized eye care in the form of centrifusite that is available to Indians and also people from overseas.
Thank you, sir. So just as a perspective, so when you came back from the United States and you wanted to start your own center, or you had this image of centrifusite in your mind. So what exactly was cataract surgery then, and how did your stepping into, how did that transform? So if, let me rephrase, what exactly is phacoemulsification, which is thrown around a lot. Not lots of people understand what is phacoemulsification.
Well, for a person to understand, let's first, rather than talk about phacoemulsification, let's understand what is cataract. So if you look at cataract, essentially, if you look at the eye, if this is the model of the eye, you can actually see that the light comes from here. This is the cornea, and then this is a clear lens which is placed here. So this clear lens, every one of us has a clear lens. So the light goes through the cornea, goes through the lens, and comes onto focus at the retina. Now, if this lens, instead of being transparent, as you can see, if it becomes clouded, like it becomes opaque, then what will happen? The light which is going through the cornea gets stuck here, it does not reach the retina. Now, in the absence of any known medical cure, there are some people who claim that there are medical cures, which is not there. What is done is that this cataract has to be removed and has to be replaced by an artificial clear lens. So exactly from the same place where the cataract is removed, you are putting an artificial clear lens. So this is basically the technique of cataract surgery, that you are removing a crowded lens and replacing it by an artificial lens. Now, thank you. Now, when you are replacing it by an artificial lens, the lens obviously helps refocus the light onto the retina. Now, what are the techniques for removing this cataract surgery? If you look at it, India was again the pioneer in cataract surgery, and it's way back several centuries ago that Shushruta defined something as couching. So where the clouded lens was just tumbled back into the back part of the eye, so that it became clear. But then a person was left with a thick power glass that a person had to use. Maybe glasses weren't there at that particular time. So there was a refractive error that was induced, because the original lens has a power, and you are just tumbling it back, and you were not replacing it by another lens which had a power to do that. Now, the lens first process was to tumble it back. Then the process came, you made a large incision, and you would take the lens out in one single piece. Okay. This was called as intracapsular cataract extraction. And
how would you close that big incision?
Yeah, so earlier there were no sutures also.
Okay.
So the patients were supposed to keep their head stable in sandbags for weeks, and that was a big painful event in the sense it wasn't an easy thing. Then came in sutures, etc. That means you had to tie up sutures to close the incision. So from there on, there was a discovery of this technique wherein the cataract was to be broken into small little pieces. So you have a large lens, you break it into small pieces and you suck it out.
Okay.
So it's like pulverizing a cataract. So this technique was called as phacoemulsification. This started in 1967. Okay. This technique, what would happen is, phaco means lens, emulsification, as I told you, you emulsify like in a mixie, आप चूरा बना दें किसी चीज़ का, तो उसको emulsify करते हैं. तो phaco lens को emulsify किया. What does it mean? A large piece has been broken up into small pieces, and there is a hollow titanium needle, a needle which is made of titanium, which is hollow from inside. So this needle is moving at the speed of sound.
Okay, ultrasonic.
Yeah, it's actually not ultrasonic energy or anything, but it's moving at the speed of sound. So the broken pieces of the cataract are taken out from this by this hollow titanium needle. So obviously all that is required is that you have to go into a small incision and take this hollow titanium needle with an irrigating sleeve into the eye. So this has shrunk the incision to less than 2.5, 2 millimeters, 3 millimeters. So that's the size of the incision. So from a large incision that you used to have, which could be like a semicircle, half circle that you had to take out the entire lens, you have shrunk the incision.
Okay.
So what has happened is that it has turned this technique of phacoemulsification into a no-stitch cataract surgery. Now, simultaneously, as I told you, what has happened in phacoemulsification is that if this is a lens, this lens is a foldable lens. You can fold it onto itself. So once you have taken out the cataract from a small incision where the needle went in and you shrunk the incision, you have taken out. Now this lens, this I am folding it, you can fold it by a holder folder, that is the older technique, but nowadays it comes preloaded into injectors. So you have like an injector in which this lens is there and you just push it, and once it goes, it opens to its full size.
Okay.
So therefore the incision has shrunk both from the point of view of being able to take out the cataract, which is by the technique of phacoemulsification, and putting in a foldable intraocular lens. ये लेंस को जो हम आँख में डालते हैं उसको हम intraocular lens कहते हैं. Intra means within, ocular means आँख. तो आँख के अंदर जो लेंस को डालते हैं उसको IOL या intraocular lens कहते हैं.
सर हर कैटरैक्ट सर्जरी के बाद हम लेंस डालते हैं आँख में.
आज की तारीख में until of course there is some complication at the time of the surgery, जो सपोर्ट होती है जिसपे हम लेंस को रेस्ट करते हैं, वो अगर कॉम्प्रोमाइज़ हो जाए तो उस केस में हम लेंस नहीं डाल पाते. उसके लिए फिर और टेक्निक्स आती हैं, स्क्लेरल फिक्सेटेड वगैरह. बट टिपिकली आप चीज़ एक इमेजिन करिए, कैमरा है आपके पास, कैमरा के अंदर एक लेंस है. अगर आप लेंस ही निकाल दें तो वो फोकस कैसे करेगा? तो उस लेंस को जो ओरिजिनल नेचर ने क्रिएट किया है, जो इंसान का नॉर्मल लेंस है, वो लेंस को हम निकाल रहे हैं तो उसको किसी चीज़ से उसको सब्स्टिट्यूट करना पड़ेगा. सो दैट इज़ एन इंट्राओकुलर लेंस. और आज की तारीख में जो टेक्नोलॉजीज़ हैं, वो टेक्नोलॉजी से हम काफ़ी सटीकता से वी कैन कैलकुलेट द पावर ऑफ द लेंस विच वी हैव टू इम्प्लांट इन द आई. सो अगर आप एक लेंस निकाल रहे हैं और व्यक्ति को पहले नंबर था चश्मे का, तो आपको एक मौका भी मिल जाता है कैटरेक्ट सर्जरी के टाइम कि मैं लेंस की पावर कैलकुलेट करूं कि ये लेंस अगर मैं आंख में डालूंगा तो ये व्यक्ति का पोस्ट ऑपरेटिवली चश्मे का नंबर क्या होगा. विद काइंड ऑफ रीजनेबल एक्यूरेसी, ग्रेट एक्यूरेसी, you are able to get the person to a desired power post operatively by using a particular power of the lens which is there.
So basically at a later stage in life also someone gets the opportunity to get a clear vision and to get glasses removed. Okay.
इसको आप कह सकते हैं एक पंथ दो काज. तो आपने कैटरेक्ट का भी समाधान किया और आपने लेंस भी ऐसा लगाया है जिससे व्यक्ति का चश्मा उतर सकता है। एक और इम्पॉर्टेंट चीज़ है लेंस की टेक्नोलॉजी, ये जो टेक्निक्स हैं कैटरेक्ट निकालने की टेक्निक्स में भी और इम्प्रूवमेंट हुई है। लेज़र असिस्टेड टेक्निक्स आ गई हैं, कैप्सुलोरेक्सिस आ गया है, जेप्टो आ गया है, बट सबसे मेजर जो रेवोल्यूशन हुआ है उसको हम फेम्टोसेकंड लेज़र कहते हैं। तो जैसे जैसे कैटरेक्ट निकालने की टेक्निक्स और इम्प्रूव हुई हैं, फेको की मशीन बहुत इम्प्रूव हुई हैं, जब हम इसको निकाल रहे हैं और लेंस जो डाल रहे हैं, तो लेंस के अंदर भी काफ़ी ज़्यादा टेक्नोलॉजिकल इम्प्रूवमेंट हुई है इन द फील्ड ऑफ ऑप्टिक्स। पहले जो लेंस होते थे जो बने थे, और अगर आप कैटरेक्ट सर्जरी के लेंस के बारे में बात करें तो पहले लेंस नहीं डाला जाते थे, कैटरेक्ट निकाल दिया, लेंस छोड़ दिया, क्योंकि लेंस था
स्टोरी है कि लेंस कैसे डिस्कवर हुए, लेंस डालना क्यों है आंख के अंदर।
तो इसकी दैट ऑल्सो हैज़ अ वेरी इंटरेस्टिंग स्टोरी, एंड वो स्टोरी ये है कि a great surgeon whom unfortunately is no longer with us in England, Sir Harold Ridley. तो वो सर्जरी कर रहे थे और उनका इंटर्न कोई बच्चा नया था, इंटर्नशिप कर रहा था, उसने पहले शायद आँख की सर्जरी ना देखी हो, तो वो देख रहा था सर्जरी, तो उन्होंने कैटरेक्ट निकाल दिया और टाँके लगा दिए, सर्जरी ख़त्म हो गई। तो वो इंटर्न ने उनसे पूछा कि सर आपने व्यक्ति का लेंस तो निकाल दिया है, मगर उसकी जगह नया लेंस क्यों नहीं डाला? सो दैट वाज अ थॉट विच अ यंग किड, एन इंटर्न kind of put in somebody's mind कि if you are removing somebody's lens, why are you not replacing it by something? उसके साथ ही उनके क्लिनिक में ओपीडी में वर्ल्ड वॉर 2 थी उस टाइम, तो कोई पायलट था, उसका ही हैड अ वॉर इंजरी, तो उसका जो पायलट का जो perspex का ग्लास होता है, जैसे कनोपी होती है या ग्लास की जो होती है, दैट इज प्लास्टिक मटेरियल विच इज़ कॉल्ड एज perspex, वो शैटर हुआ था, एंड दैट ग्लास पीस और दैट perspex पीस वाज लाइंग विद इन द आई विदाउट इनसाइटिंग एनी इन्फ्लेमेशन। तो वो उनको दिखा कि ये जो मटेरियल है ये आई में इनर्ट है, ये आई में कोई इन्फ्लेमेशन नहीं कॉज कर रहा। तो बच्चे ने सवाल पूछा, इधर इन्होंने एक इंडिपेंडेंट ऑब्जर्वेशन करी कि ये मटेरियल जो है ये आंख में रिएक्शन नहीं कॉज कर रहा, दोनों का दिमाग उनकी उपज, उससे उन्होंने मिश्रण करके ये बोला कि हम अगर इस चीज़ का लेंस एक आर्टिफिशियल कृत्रिम लेंस बना दें और वो आंख में डाल दें तो कैसा रहेगा। एंड दैट इज हाउ द स्टोरी ऑफ इंट्राओकुलर लेंसेज स्टार्टेड। ऑब्वियसली देयर वर, हाँ जी,
इट वाज बाय एक्सीडेंट।
Oh, it was, I don't know, whatever you call it, but yes, it is ideas, जैसे एप्पल गिरा था कहते हैं तो ग्रेविटी का आइडिया आया था, वैसे ही ये आइडिया किसी ने बोला कि भाई लेंस को क्यों नहीं बदला, वहाँ से शीशा दिखा आँख में पड़ा हुआ, तो दोनों का व्यक्ति ने साइंटिफिक इवैल्यूएशन करी या मिश्रण किया या एक हाइपोथेसिस थ्रो किया, एंड दैट्स हाउ इट केम अलोंग।
Okay, nice incident, nice anecdote.
हाँ,
Coming back to the femto laser cataract surgery जो आपने बता रहे थे कि एडवांसमेंट हुआ है ओवर फेकोमल्सिफिकेशन, तो उसमें क्या फ़र्क है कि जो आजकल रोबोटिक सर्जरी, लेज़र सर्जरी, AI सर्जरी कहते हैं, वो क्या सब सेम चीज़ है? कैसे आप इसको क्या?
सो देखिए, इसमें फेम्टो लेज़र अगेन इज अ रेवोल्यूशन इन आई केयर। फेम्टो का क्या मतलब है? Femto is a measurement of time.
Right.
And a measurement of time, femto means 1/4 of a second, 10 to the power minus 15. तो आप इमेजिन भी नहीं कर सकते वो कितना छोटा, मतलब इट्स सच अ स्मॉल फ्रैक्शन ऑफ टाइम। सो femtosecond लेजर is a high intensity beam or a laser pulse that hits at a specified target. And it causes disruption. So it is a photo disruptive laser. And ये लेज़र जो है अगर हम टारगेटेड इसको एक पर्टिकुलर जगह पे हिट करते हैं तो उससे कुछ असर आता है। When it hits, it creates plasma. वो एक्सपैंड करता है, तो हम उससे इसको एक कटिंग लेज़र की तरह यूज़ कर सकते हैं। तो सबसे पहले जो फेम्टोसेकंड लेज़र है वो इस्तेमाल में आया रिफ्रैक्टिव सर्जरी में, चश्मा उतारने की विधि में, कि जो पुतली है सामने की कॉर्निया है उसको हम अगर कट करना चाहते हैं तो उसके लिए ये लेज़र यूज़ हुआ कि इंसीजन बनानी है अगर मोतिये के ऑपरेशन की, या लैसिक में फ्लैप बनाना है उसके लिए, या बाद में अभी केलेक्स या लेंटिकुलर एक्सट्रैक्शन है उसके लिए। उसके बाद ये लेज़र जो है, द सेम लेज़र वाज मॉडिफाइड। मॉडिफिकेशन इज इन द न्यूमेरिकल अपर्चर या फोकसिंग मैकेनिज्म, कि आप उसको किस लेवल तक फोकस कर सकते हैं। तो ये फोकस करके आज की तारीख में कैटरैक्ट सर्जरी के अंदर इस्तेमाल होता है। तो फेम्टोसेकंड लेज़र डज 4 steps ऑफ कैटरैक्ट सर्जरी and it complements and is supplemented by phacoemulsification. So 4 steps which are computer controlled, which are basis getting a picture of the front of the eye, and then by AI planning the incision, planning the nuclear breaking, जो मैंने आपको phacoemulsification बताया कि उसको छोटे छोटे टुकड़ों में पहले मैनुअली जो अल्ट्रासोनिक स्पीड पे जो नीडल चल रही है उसके मैकेनिकल डिसरप्शन या इम्प्लोजन से वो उसको तोड़ते थे, वो आज की तारीख से ये लेज़र को आप डिफरेंट कट्स में काट सकते हैं और इसके छोटे छोटे टुकड़े कर सकते हैं। तो आपको एक प्री कट न्यूक्लियस मिल जाता है, यानी कि जो कैटरैक्ट है वो प्री कट हो जाता है। इंसीजन प्री कट हो गई, आपने मतलब कि जो एंटर करने के लिए नीडल वगैरह है वो प्री कट हो गया। एक राउंड ओपनिंग बनाते हैं कैप्सुलर एक्सिस, वो हो गई, तो वो भी कंप्यूटर कंट्रोल्ड AI विद इमेज वगैरह होती है, और कैटरैक्ट के छोटे छोटे टुकड़े हो गए ताकि हम उसको ज़्यादा आसानी से सक आउट कर सकें। और चौथी चीज़ जो ये लेज़र करता है वो अगर किसी को सिलेंड्रिकल पावर है, कम थोड़ी सिलेंड्रिकल पावर है, तो उसमें हम एक इंसीजन बना के उसको भी कॉर्निया के आकार को सही कर सकते हैं। सो दिस इज कॉल्ड एज फेम्टोसेकंड लेज़र या फेम्टोसेकंड लेज़र असिस्टेड कैटरैक्ट सर्जरी। ठीक है, तो इसको आप दूसरा नाम दे सकते हैं कि रोबोटिक, सेमी रोबोटिक कैटरैक्ट सर्जरी कह सकते हैं। AI का इस्तेमाल होता है कि कैटरैक्ट को कैसे कैसे छोटे छोटे पार्ट करने हैं, द मशीन विल थ्रो अप थ्रू AI के उसको क्या क्या सेटिंग्स होनी चाहिए। आपका एस्टिग्मेटिज्म कंट्रोल के लिए वो नोमोग्राम्स बने हुए हैं AI के ज़रिए कि कहाँ पे आपको सिलेंड्रिकल पावर करेक्ट करनी है या कहाँ इंसीजन वगैरह करनी है। कैप्सूल को आपने कहाँ पे करना है, इमेज आई, इमेज के साथ डेटा हुआ, डेटा को AI के ज़रिए आपने वापस भेजा, और कैप्सूलॉटमी आपने सेंटर में करनी है, प्यूपल के एक्सिस में करनी है, विजुअल एक्सिस में करनी है, या आपको कैप्सूल के सेंटर में करनी है, वो कई चीज़ें हैं। तो दिस इज़ बेसिकली what femtosecond laser is. So people call it as semi-robotic cataract surgery, AI generated cataract surgery, femto laser assisted cataract surgery, flax वगैरह, ये उसके कई प्रकार के नाम हैं जिसको बोलते हैं।
So basically it is doing the critical part of the surgery, so it's making the surgery safer.
Safer, apart from safety, more predictable, more customizable. It's like a customizable surgery for each individual eye. And the outcomes are repeatable. So human intervention का थोड़ा सा requirement कम हो जाती है। पहले when you are not using it, the skill sets are also very important. In this particular case, since there is something that is being generated, image चाहे वो मेरे लिए generate हो या आपके लिए generate हो as a surgeon या किसी और के लिए हो, वो तो same होगी। And then the machine is going to also be telling you that this is where you should be doing and what should be done. तो इसलिए थोड़ा सा उसमें skill requirement and chances of getting complications go down. It's safer to the eye, it's more comfortable to the eye, it's maybe faster visual rehabilitation, customizable results which are more predictable.
So I have seen you operate in the operation theater. मैंने देखा कि आप बहुत फास्ट सर्जरी करते हो। तो एक एवरेज ऑप्थेल्मोलॉजिस्ट सर्जरी कितने में कर सकता है और आप कितने फास्ट कर सकते हो?
देखिए, फास्ट करना एक सेपरेट चीज़ है और सही करना एक सेपरेट चीज़ है। सो यू हैव टू कंबाइन योर स्किल सेट्स and deliver them in such a manner that you are giving an efficient, good, quick result. मैं एक पर्टिकुलर चीज़ को बिलीव करता हूँ कि सर्जिकल टाइम जितना कम होगा उतना टिश्यू ट्रॉमा कम होगा.
Okay, makes sense.
और टिश्यू ट्रॉमा कम होगा तो आउटकम्स आर फास्टर एंड बेटर. So that is something which is very important. False moves should not be there. What you are doing is goal directed. कि ये चीज़ होनी है, उसके बाद ये स्टेप होना है, उसके बाद ये स्टेप होना है. तो उसमें पूरी टीम का एक रिक्वायरमेंट होती है कि आपने हाथ आगे बढ़ाया तो सिस्टर ने आपको जो नेक्स्ट इंस्ट्रूमेंट है वो तुरंत दे दिया. आपको माइक्रोस्कोप की एडजस्टमेंट करनी है. सो बेसिकली द पॉइंट इज एफिशिएंसी. And that's one of our pillars of Center for Sight, precision, efficiency. And these two things, apart from our compassion, which is also part of it, but you have to be precise and you have to be efficient. So I think for a common person, phacoemulsification procedure may take maybe 20 minutes, 15 minutes. We can possibly do it in a couple of minutes.
Wow.
Yeah.
Okay, so you can do possibly 10 surgeries in the time someone can do.
Again, I think there have been great teachers where we have seen there has been a railroad kind of an approach. There has been an approach of having different OTs being ready and teamwork there along with it. So yes, you have to be efficient because India has a huge workload as regards cataracts. India does about close to 80 lakh surgeries a year, which is more than US plus maybe China and part of Europe put together. So the number of surgeons that India has today are about ophthalmic surgeons, maybe about 35,000. And maybe not all of them are operating. So an individual workload can be pretty significant. So you have to be efficient and give excellent results.
So I want to come on to how the scene of refractive surgery was in India. But before that, I want to know that in your, since you are doing clinical work, also doing surgeries, you have your clinics, and you're also doing managerial aspect of ophthalmology, managing so many eye centers. So what does a typical day look for you? How many hours in a day do you work?
Well, I think...
and is there anything as work-life balance?
Well, I am now not at a stage where I am looking at a work-life balance because work has been kind of something which has been part of my life. And I don't think there are any free lunches in life. So you need to be working hard and you need to be focused. So I often say that for building an institution or for building a legacy, that's what I tell my people that, well, you have to eat, breathe, drink, sleep, Center for Sight. So that's my balance, focus. I think focus is the balance that you have. And that's what life, I personally feel a person has to go through the journey of life. And if what you are doing gives you happiness, gives you the satisfaction, that's what drives me. And yes, I do take small vacations in between, but that's about it. Do tend to relax, but yes, that is the work-life balance that I have.
So there is no balance. So in a typical day, so how is your day? A typical day?
Well, my day starts at about maybe 5:45 or 6 or 6:15, depending on the number of surgeries I have. And morning, I do stationary cycling for about 30 to 45 minutes, reading 3 to 4 newspapers, and that's how it is. And after that, get ready, and I hit the OT around 8:15, 8:30, 8:45, again depending on the number of cases. Thereon finish the OT and then do my OPD clinics. And after that...
So typically how many surgeries do you do in a day, and typically how many patients do you see in a day?
Well, it all depends. I could be seeing 30 to 60 to 70 patients or 80 patients, maybe at times even goes up to 100 patients a day. And surgeries can also be ranging from anywhere between 10 to 30. So that's one. I have days earmarked for surgery, which would be 4 in a week. And then on, obviously, in between, there is teaching, there is fellows with us, there is administrative work, in between research, writing papers, and then management, administration, thinking of growth, thinking of how to get the best out of the team set aside. So that's how the thing is. Expansion nowadays. Organic, inorganic growth, both are important. So you have to do fundraise. So all these things come along.
So thank you, sir, for being with us and sharing your experience and your journey in ophthalmology. There's so much more to learn from you. We can't incorporate all this in one episode, but still knowing and being part of a journey through cataract surgery and refractive surgery was very enlightening. And I'm sure we all have, as I have learned from you, we all have so much to learn from you. And I'm sure you will keep teaching us. Thank you for being
It's entirely my pleasure, and I hope that people go out enriched with more knowledge about the advances in ophthalmology, more so in phacoemulsification and refractive surgery. Thank you.
Thank you, sir. So for more such informational videos and more such videos that speak about facts, please follow Center for Sight so you may enhance your knowledge in ophthalmology. Thank you.